quickly, I'm going to transition to Dr. Paul Plummer to open it up for a roundtable, but I just want to encourage especially our new members to please speak up and comment during this roundtable session. It's when we really get some great discussions going. With that, Paul?
All right, thank you, Sarah, and I echo my appreciation for the CDC presenters, and thank you for that. So as Sarah mentioned, this is going to be an opportunity to hopefully hear some short comments from a variety of folks. I'll make some quick comments, and then we're going to let you raise your hand and volunteer. If we run out of questions or comments, I may start calling on people, but I like Sarah, want to make sure that those of you that haven't asked questions or might be new feel free to go ahead and do so. So as I reflect on what I've heard here today, two things I've heard, and then tying those together, I've heard repeatedly, which I'm very pleased about, the comments around One Health. Everything from G7, G20, all APEC, all of the different USAID, CDC. One Health has come up in each of those, and appropriately so. And in my mind, that's an area I'm passionate about. I've heard about resource limitations, and I think that's also an underlying theme here that we need to consider as a council. That said, I have heard very limited about plants, limited about environment. I don't think I heard anybody talk about companion animals, dogs or cats, which is a huge interface in terms of One Health. And, I believe, at least in the work that we've done, that there's an even greater resource discrepancy and funding issue as it relates to One Health. We hear all of the groups talking about this on a global scale, but when we look at resource and funding, there's a disparity between funds going into, those One Health efforts. And the reason we didn't hear much about companion animals today is because no federal agency has kind of companion animals as a primary mission in their role. And so I would encourage us as a council to really particularly focus and consider in our report leveraging this global interest in One Health and belief that One Health approaches are critical to addressing AMR, and taking that opportunity to encourage resources being put into alternatives to antimicrobials in the One Health space, alternatives in plants. Alternatives are new mechanisms to prevent disease and infection prevention and control in companion animals, and really the environment and all of those spaces. So with that, Robin, you're up next.
Yeah, thank you, Paul. Just some reflections. First of all, we heard from Dr. Clara Davis about a goal of solving HIV, and we know that AMR is fundamentally linked to evolution and is so many diseases, as we heard, and so it's unlikely to be solved. So we need ongoing solutions. It's really a moving target. At stake is our health, our welfare, our security, and that for Americans is inextricably linked to what's going on globally, since microbes know no borders. I really applaud all the multifaceted approaches that we heard about today. And I have a couple of questions for reflection. First, is the level of interaction between the various groups that presented today ideal? And then second, has a crosswalk been performed across the various action plans and activities to identify gaps and areas of redundancy and or synergy? And I don't know how this goes as far as a discussion, but those are just some of my thoughts.
Yes, thank you, Robin. So generally we don't do questions here, but those are great questions that we now can take back to the working group and explore in this next thing. So that's exactly what we're looking for from those that haven't participated before, is raising those questions, those gaps, and then those inform where the working group heads next on who we invite to speak and topics that we're seeking. So appreciate that, Robin. Virginia.
Thanks, Paul. And those are what you said, and what Robin just said is kind of a good segue into maybe it's a request and maybe it's just me, but I mean, this is a complicated topic, and we heard today, which we've heard in many meetings, the complicated pieces of effort that are going on clearly around the world. It would be really helpful to me and potentially helpful to other people that are trying to grasp some of these issues, particularly the global aspect of it, is what are some visualizations or graphical representations of the interactions, the groups across the world. And I think that the crosswalk, like we were just talking about, is a great approach to, and maybe overlay that with what is, and I like visuals. I can't create them myself, but I find them really helpful. And so trying to visualize who are the parties, where are things happening and where are they not happening, whether geographically or in, virtually or in different spaces within One Health. And can we use some of that sort of graphical representation to identify redundancies or gaps or potential for synergy?
Excellent. Ling, go ahead.
Thank you, Paul. First of all, as a new PACCARB member, this has been a tremendous opportunity for me to hear from across the groups. And of course, even though we have representation, we didn't hear from a lot of other important groups, NIH, FDA, ASPR, DOD, et cetera, et cetera. So this is just, a taste, if you will, of what's going on. The call for resources, I think, as others have said, is important. But my concern when we think about an international approach to this is how efficient use of resources there is within our plan. So arguably, it's better to have a national action plan than to not have one. But if it's not actionable, either because it's not feasible economically or whatever, what role can we play moving forward in terms of finding solutions that actually can be implemented and sort of remove the barriers so that the action plans can actually come to fruition? And then another theme for me, just listening to everyone, is how do we better coordinate the coordinators? I mean, we heard from a lot of groups today, but then there's non-governmental groups, industry, academia, trade organizations. I mean, just an enormous number of stakeholders and players. And how do we coordinate the coordinators of those roles more effectively so that they're actually the messages are more aligned, they're simplified, and then they're more implementable in the various countries. Also across the methodologies, WASH, IPC, vaccines, therapeutics, diagnostics, surveillance system, detection, all those methodologies, and how do they interplay with each other rather than just being silos that are implemented individually? How can they co-advocate, co-promote each other's activities? Also seems to be potentially a role. And then, as I mentioned at the very beginning, the disease area overlap. Gain talks about antimicrobial resistance as well as healthcare associated infections. I mentioned the interplay of the Venn diagram with sepsis also. So there are activities that are focused on these roles that, again, are independent rather than more joined up for messaging, funding, resource utilization. And then in terms of our leadership internationally, a lot of activities that we have, we lead from the front. We take pride in that as a government, as a country, but we also focus on leading from within. So joining other groups seems to be another theme, and how can we look at that more effectively so that we don't have to expend resources to lead everything? We join more, we encourage others to join. And then finally, lead by following. So I think as we hopefully implement more national action plans in countries, especially low and middle, if they come up with solutions that are more efficient use of their resources, how do we follow those and implement them perhaps in our own country, but make sure they're shared with other countries so that we're not just, again, sending it out the messages to the countries, but we are a coordinator of great ideas, best practices of the show. Again, thank you for allowing me to participate today.
All right. Thanks, Lynn. Emily, take it away.
Great, thank you. So thank you to Paul and also to Jason for your leadership chairing today's meeting. And I also want to express gratitude to the USG colleagues that shared about the global landscape for AMR activities and key achievements over the last decade with an eye to truly a global response to AMR. Similarly to some of Virginia's comments just now, I thought it was extremely helpful to see the various timelines and snapshots of activities visualized on the screen of activities across the different agencies and offices over the past decade. That was immensely helpful to see that all compiled together. And I don't believe that I'd seen that comprehensively put forward as we saw today. I think that the challenges that continue to persist across the antimicrobial ecosystem were also a common theme across presentations today. And particularly, experts flagged the importance of public-private partnerships as paramount to address AMR challenges and the need on a global scale to support the development of antimicrobials. In the context of this, one comment that really stood out to me was when colleagues at OGA noted that promoting and supporting the development of antimicrobials has been a mixed bag, which I think couldn't be more true. In the last decade, I believe it's been 8 antibiotics that have been developed by small companies that have reached FDA approval. But today, every company behind those antibiotics has either filed for bankruptcy, was forced to sell, or has downsized or exited antimicrobial R&D. And this is, of course, not only a problem for these companies, but for the innovation ecosystem broadly. So on that same note, I was really pleased to hear continued recognition from folks today on the need to align and advocate or align and advance economic pull incentives for antimicrobials, which is a theme that we've seen in global discussions, paired, of course, with strengthened stewardship and access considerations, which is really needed to stabilize this ecosystem. I think it's really important to note that the USG has consistently acknowledged the need for a decoupled pull incentive to address the unique challenges of the antimicrobial R&D ecosystem. And there are a number of other countries that are exploring and advancing pull incentives as well, including the UK, Japan, Canada. And this is really a key part of the puzzle. Again, I think it was great to hear some additional details surrounding the APEC meeting earlier this year, and having a key theme of that meeting being the recognition of pull incentives and really aligning on a global stage. So I think my call and real reflection here would be building on PACCARB's resolution back in 2021 that expressed support for legislation that promotes the production of new antimicrobial drugs. I'd urge the PACCARB to explore ways to engage on the critical need for pull incentives and antimicrobial R&D support as the Council continues to consider and explore hot topics for discussions around UNGA.
Right, thanks, Emily. Libby.
Thanks, Paul, and thanks, Jason. All the previous commenters have just been very impressed by the complement of activities across the U.S. government that are working towards combating antibiotic resistance. And I think that it's also, I wholeheartedly agree about doing sort of an inventory of what is there. It was great to see all that today and to have some way to consolidate it. But when I think back to the task that we were given, I just want to put out there as food for thought, and perhaps maybe at future meetings. You know, I work at a university that has an international campus. I know many of my colleagues on this call in academia do the same. We are doing work in Asia, and whenever we go to Asia, we literally run into friends in the airport who are doing similar work that we knew nothing about. And so I'd like to consider maybe including in this assessment work what is available at our academic partners and through our professional societies. I know that the SIDP has actually just launched an international task force. I know that that's an area in many other professional organizations, but I think if we're really going to help fully define the way, as we've been tasked, of how we can lead this combating antimicrobial resistance work, I would really encourage us to think of all of these other partnerships that we need to also assess and somehow inventory so that we can best leverage that for this work. Thank you.
Wonderful.
Thank you.
Appreciate Susan.
Hi, thanks for everybody. I'm sorry I'm not on video anymore, but I wanted to mention that this was just a terrific tour de force to really understand what just the tip of the iceberg of all the good work that's being done. I wanted to echo the comment that was made earlier about it would be really helpful as we think about all of the NAPs, the National Action Plans, and other types of things that others are doing to get a high level overview of what are the synergies of what people are doing, and how do they overlap to certain types of stages or steps of where countries are. And the reason why I raise that is when we think about the comments we've been having today, and there was a time when I used to think, wow, there's trade, and there's agricultural movement, and there's people movement, and there's all sorts of food stages that are being moved around the country, and it's too much for us to think about all of these spheres all at once. And I think that technology now makes that possible. And what I mean by that is we are absolutely one world, and we need to work towards one health. But within that, even within the United States, but certainly within the world, there are smaller ecosystems, smaller network analyses that can be done to understand how all of that rolls up into the world. And I'm just wondering, with all of these wonderful levers that we have, is it now possible to use the technological advances to create a very large network analysis of the way in which plants, food, people, and other types of goods are shared, so that we can understand which things drive AMR better and into which smaller spheres that then add up into the larger spheres. And there's very likely connectivity between countries, just like there are within the United States of certain regions, where we can clearly see different ecosystems where our own AMR is different regionally. So I just wanted to raise that kind of high level view as we're talking about global analyses, and how we can think about where we can best impact antibiotic resistance suppression. And the last thing I just want to say is to echo again this really terrific axis of talking at least about the prevention stage for colonization, and how that might also be an additional important place to go. Thanks very much.
Thanks, Susan. Julie.
Great. Thank you so much. And again, I will, at the risk of, redundancy, just say how much I enjoyed today, how much I learned. I also want to echo strongly the points about sort of bringing all of these many threads together for us to sort of understand what's going on in a sort of coherent way. But one point, one theme that was really bouncing around my head that really started with our patient story from Dr. Shamas, and I think came up in bits and pieces throughout the presentations today, but is something I hope we can take forward, particularly in our future public meeting, is thinking a little bit more about implementation and adaptation to the local context of places that are very different from the United States, that have incredibly different infrastructure, culture, political challenges, and that, we want to be a leader in AMR, but can we lead without being paternalistic, for lack of a better word, in terms of sort of, we have a vision about what this should look like, but making sure that we're engaging and partnering with people who are coming from places that are very different from our own, and ensuring that that's knit into all of the recommendations we make. So that's more of a theme moving forward. I know we're going to have a future public meeting that will engage with other partners across the globe, but I just wanted to put that out there. Thank you.
Thank you, Julie. And loving the comments. I just want to flag that we're about halfway through our comment period, and we still got a lot of hands. So if folks, we want to hear your comments, but try and keep them brief so that we can get everybody through. So Brian, you're up.
Yeah, I'll keep mine really short because Julie stole it. I was really struck this morning. Great presentations throughout the day, but I was really struck with Dr. Shamas's presentation, and the word stigma stuck out in my mind all day long. And I was thinking, like, as we go to different parts of the world, as we go to even the different sectors within One Health, I'll speak from ag, that word stigma comes up. And so I think we need to have a very concerted approach when we go into the different niches that we're all trying to coordinate, to be aware of those stigmas so that we can almost preemptively overcome them. So thanks for stealing all my comments, Julie. I'll raise my hand earlier next time.
Thanks, Brian. Francisco.
Well, also Julia stole my comment together with Lynn, so I have not much more to say. But I guess a couple of very brief points. Trying to go back to the question, the way I summarize our task is how can US agencies and the US in general lead global AMR efforts using a One Health approach? And I think this leading, it's important in my mind. The one comment that already Julie made, I'm not going to reemphasize, is, we cannot try to apply the US model to LMIC countries because it won't work. I have been there. I have failed miserably and completely acknowledge I have. But the other aspect is that there are other leading nations and groups today, specifically the EU, who also have a different model than we have to some respect. So I think that will be important to not just emphasize what the US does better, perhaps, or worse than the EU, but also try to bridge that gap so that others can understand why we do things differently than perhaps the EU, Japan, and other nations. Thank you very much.
Great. Thanks, Francisco Peo.
Yeah, I think one thing that I was struck by, and I'm always struck by when I think about AMR, is just the amount of barriers and then also the amount of interventions that we have to hopefully fight this problem. And I think as we think about this on the global scale with our task outlined for us, it's important to think about potency of interventions. What is the juice worth the squeeze? And as I think about that, I think about how much like we've already done in the US with antimicrobial stewardship. We're really a leader in antimicrobial stewardship. And one of the easy ways, I think, out of all of the interventions is really educating on antimicrobial stewardship. We heard a lot about education. We heard about stewardship, but we didn't hear about technical ways that we were really getting out into countries and targeting improving education on antimicrobial stewardship, whether it's for healthcare workers or someone else. So I think as we think about potency, as we write our report, that'll be really helpful because often you really have to get those efficient interventions for them to work.
Awesome. Jason.
I'm so appreciative to be a part of an amazing council and great to be in here and can't wait for more. My themes is the following: from simple to complex. Whether it was 100 years ago when Calvin Coolidge as president lost his son to a simple Staph aureus skin and soft tissue infection of a toe following playing tennis barefoot on the White House lawn, to now talking about antimicrobial resistance at levels in low and middle income countries and neonates that can't be treated by meropenem. That's how it's changed, and we can do amazing things in medicine. And what we have heard today was that we have a lot of complex systems in place to try to help combat what we're seeing. And it does come down, I think, for me, simply, can we prevent more? Can we prevent more infections? Can we prevent more? And it's gonna take a lot of this, whether it was the colonization we heard about and some of the efforts there, to just maybe more vaccinations, and how do we advocate that? So that's what I'll hear and heard today, and look forward to more conversations as we move forward. Thank you, Paul.
Tim.
And to complement all the great statements that have already been made, one of the things that we heard about is the importance of international engagement and the role of coordination. I think we need to focus a lot on that. Something that I heard earlier and hasn't been commented on, though, is the importance of understanding politics. We're an expert group coming together. We can talk about things from a technical perspective, but we must not forget the importance of politics here. First of all, politics is what gives the mandate for action and makes things actionable, and also is a route through to sustainable funding and other things. So I think there has to be further consideration of that political engagement and what's necessary to support that and arrive at a point of evidence-based decision making. We've seen things that tell us there's an implementation crisis, and how to help overcome that implementation crisis. And very importantly, there needs to be a prioritization that is relevant to local circumstances. And that's the challenge here, is how can, particularly from a US perspective, taking a leadership role to help support priorities in places which are very different from the US. Lastly, just want to say systems approach idea, excellent. We need to think about that. Thank you.
Wonderful. Padme.
Yeah, thanks. Thanks to all the council members for their great comments. I really second a number of those. and really wonderful presentations today. I think a couple of concerns I wanted to raise for us to think about is around the targets that will hopefully be proposed and hopefully be a point of discussion in the high-level meeting, and making sure that these targets reflect the needs of low and middle income countries also. I think that there's a real risk that those low middle income country priorities and capacities are not going to be well reflected in proposed targets. And USG, I think, has a role, particularly reflected in all of the work, CDC colleagues and USAID colleagues presented and shared to have those insights. And I think that would be an important role that USG could play. The second is we heard that these activities are resource intensive, and there's been a huge step change in understanding of AMR burden and generating better data. But how can we actually, if in order for all of this to be sustainable, I think that there's a real need for innovation and thinking about how can we generate these data that are then actionable and link them to action, to prevention, to actions, to respond in ways that are truly cost effective. And finally, recognizing that if we continue to talk about AMR as an AMR problem, we're not going to succeed. We need to talk about AMR as an MNCH problem. We need to talk about AMR as a primary healthcare problem, and that level of integration with other realms of public health, which are outside traditional infectious disease or antimicrobial resistance discourse, is going to be critical. Linking these to sustainable development goals that will otherwise not be met if we don't actually action on AMR is going to be ways to really advance the needs for resources. So thanks so much, and I'll turn back to you, Paul.
Thank you. Lucas.
Well, thanks, Paul. I just was blown away by listening to all the speakers and learning about the complexities and challenges and opportunities of all the what the U.S. is engaging in at the local and international level about this very complex problem. And I think a phrase that I get from one of the speakers is the importance of coordination of this U.S. engagement and the importance of partnerships, because as they say, really partnerships is what help us to learn and to inform the global architecture on AMR. So, either public-private partnerships of different sectors and bringing people from different sectors with a One Health framework is key to really understand and tackle this very complex problem that is not only the US, but it's also globally, and how we adapt it at the local level, as many of you have just stated, is truly important. And then, one more thing that, as I asked in my question, and adding to the disciplines that we have missed bringing to the table, looking at the One Health umbrella that Paul mentioned, probably, communication science, behavioral science, and educational science probably need to be part of the conversation as well, because it's very difficult to really communicate to the different levels. For example, cattle producers or the public or pet owners about, why AMR is important, and more importantly, what are the positive things that are being done about it. Thank you very much for the opportunity.
Thanks, Lucas. Tom.
Yeah, thanks, Paul. I don't have too much to add to what's already been said. I guess that's a good lesson for us new members, is to get our hands up early. But I just wanted to say how impressive the presentations were, and how really could kind of see the breadth and complexity of the U.S. engagement on the globe, on the AMR on a global level. We saw get all these different agencies and programs and individuals engaged with other governments and international agencies and partners on diverse topics, and just makes me wonder, as has already been mentioned, is there room for better coordination of those efforts? How much duplication of effort is going on? Could we have a better response and do a better job if there were some better way to coordinate those efforts? I don't know if we need that, but I think it's a question that we should consider as a council.
Excellent. Thanks, Tom. Sarah.
Well, as a federal partner, I was at the end of the line, but there's others behind me. I'll be very brief. So, even myself, I learned a lot, connected a lot of dots today. The one thing I would build on, I would say just very quickly, is that, it seems that, working together is extremely important. And we've had a glimpse at the extensive resources dedicated to carrying out all these activities. Often we're seeing that, the idea is that we should be adding more activities, right, and to combat this problem. But I think we potentially as a whole should take the perspective of that may not be the first answer, but to continue to coordinate and leverage and invest in our existing activities to strengthen them. So a little twist on what others have said. Thank you.
Thank you, Sarah. Stephanie.
Hi, I'll be very brief, but building I think also on what Julie had said about kind of being humble about coming from the US and making recommendations, especially to low and middle income countries. And I'm just relaying my own personal experience of going to under-resourced facilities and hearing from them what the challenges and barriers are. And I just wanted to ask if it would even, maybe this isn't possible, but if it would be possible to hear from a low middle income country who has had some success in implementing strategies to combat AMR, so we could hear from them what their barriers were, would be really additive, if that would be possible at a future council meeting. Just wanted to raise that as a possibility. Thanks.
Sounds great. Thanks, Stephanie. Claire.
So thanks. That was a very overwhelming amount of information. I think my brain's melted. So this is probably going to sound a little bit more stream of conscious than I would like, but I think like a lot of folks, the personal AMR story really made a huge impression on me. And honestly, one of the things that was said that I hadn't really thought about before was, well, how do we define AMR? And that could be something that might look different in other countries, depending on language or, relationship to the healthcare system or whatever. And, as a veterinarian and as someone who works with susceptibility test data, these definitions it's like the devil's in the details. And so I think the language around how we define things, how we communicate about AMR, like what are we even speaking about the same thing? And I think that really made a huge impression, is that are we even having, the same conversation across all of these different sectors? Because even between human health and veterinary sectors, when we talk about AMR, can be really, really vastly different, even though we think we're talking about the same thing. And so, her description about, is AMR what we should be calling this, I think really made like a profoundly mind-melting sort of impression upon me, because, the language, the communication, the definitions, the understanding is so foundational, especially if we're working across these really diverse areas and across different countries with different capacity. That seemed really important for all these efforts to be, as fruitful as possible, I think. I think the other thing that I guess I wanted to highlight too is there's been some discussion about education and educating around stewardship, but there hasn't been any mention of like formal education, and having that be something that we can support in the different areas. I know on the veterinary side, we don't have a lot of people who do this kind of work. And we don't have good training opportunities in that area, even within the United States. And so I think, discussions about how we can have like more formal educational infrastructure in countries would be really helpful, because there just are not that many people. And I think that educational infrastructure is a huge part of the sustainability of some of these programs, and not just dumping people into countries or bringing people here, but having a sustained infrastructure, where it's needed. And I guess the last thing, sorry, I'm I could talk forever, is that, when the gentleman from the kind of the plant sector was talking, he was calling things pests, and this is a very narrow bacteria kind of focused thing, but honestly, that also was something, as we talk about fungi, we talk about parasites, we are kind of dealing with this resistance issue, and I think that's came up time and time again about missions that people were looking at across these different infectious diseases. So I don't know. I mean, obviously, this group has a name that's very specific to a type of infectious disease, but it just seems like a big miss to not have those conversations include other infectious diseases. Thank you.
Thank you, Claire. And Joni, we're going to let you go next. For the council, I have permission to go through break, but we do still need to end at the time. So Joni, we'll have you, and then Jenny, and then Michael, and then would love to hear from Jim and Armando for sure, and if we have time. So Joni, go ahead.
Hi, I just sent you a note saying I didn't have to talk.
I know, but I want to hear what you have to say. So this is an important part of the council. This is what this is where we start to formulate our working group plans. So
thank you, Paul. Thank you, everyone. Thank you, presenters. Thank you, council members, for really thoughtful comments. So the thing that struck me as being repeated over and over by different speakers was the importance of relationships and public-private partnerships. And, several of the speakers described how high-level policy agencies translate their work at 10,000 feet to actual work on the ground, which is, of course, where people need us, right? And a great example of that for me was FAO's progressive management pathway. I guess I'd like to keep that in mind for the council as perhaps a type of framework for bringing that 10,000-foot policy down to where it can actually help people in a variety of settings, like has been brought up over and over. Thank you, everyone. Those are my comments.
Thanks, Joni. Jane.
So reflecting on the conversation, I'm certainly struck by the incredible work being done and want to highlight three aspects that we should consider from the speakers. So firstly being that understanding AMR beyond the acute care setting, especially at a community level, is incredibly important, including the environment and animals, especially in LMICs. Next, when we're dealing with AMR, we should be considering both infection and colonization. And when it comes to making interventions, certainly we need to be thinking globally, but the work seems like it should be organized and led locally. That said, I want to highlight Dr. Black's comments that I would really love to hear in future meetings, those who have been successful in leading such efforts, especially from LMICs. Over.
Wonderful. Michael.
Thanks, Paul, and thanks, everybody. Two brief comments. One, to Stephanie and Dr. Kwan's comment just now. CDC happy to open up our Rolodex and connect with Sarah and others on potential folks who are working in country that we could partner with and who might be able to speak at an upcoming meeting or at a work group, and happy to help facilitate that as best we can. The other comment I would just note is that there's a lot of discussion today about laboratory capacity, and I think this is just sort of a comment for the work group. I do want to underline, because I think this is something that gets lost, is that all laboratory capacity is not equal. And in fact, when we're talking about AR laboratory capacity, it's beyond what is often normal lab capacity. It's not just setting up a lab and being able to perform one test or to be able to get a yes/no answer. When we're talking about susceptibility, we're literally getting results for, potentially dozens of antibiotics, their susceptibility, their resistances. We're dealing with 18 plus pathogens. And so just noting for some of the conversation moving forward, it's not a binary yes/no when we're dealing with AR, and when we're thinking about developing additional capacities, especially in low middle income countries, that's something to consider. And that doesn't even take into account more sophisticated tests or colonization tests the type of testing that we ideally might want and the laboratory capacity words that get bandied about aren't always the same. And I think we need to be very careful as we talk about these things, what type of capacities we're wanting to note and how we can build those specifically. Thanks.
Wonderful. Armando.
Yes, thank you, Paul. So great conversations, very rich presentations. I learned an awful lot today, so thank you for that. But a couple comments that I wanted to make. One is that, and it's what keeps me late at night, not sleeping, and I've seen it today throughout several presentations, is one word: awareness. And that word, I think we have a tendency in this country to talk the talk but not walk the walk, because we like to say awareness and bring awareness and educate, but we really don't do it. My challenge to you is when you finish the meeting today is to go to your next door neighbor and ask them what the AMR is. And most likely they look at you like you're from Mars. So if we don't invest heavily into patient education, we will never resolve AMR issues, because we already lack proper education with our experts. Imagine with the public at large. And so, and that's one issue. The other one is that bringing patients and families into this kind of work is of utmost importance, because they tend to see things from a different lens than you do. I tend to see things different from the way you do, because I'm not trained the way you are. And so if our job is to push you, the expert, and not to tell you what to do, but to push you to think outside the box, right? And so patient education is of utmost importance. And the other thing is, if we're going to bring patients and family members into this kind of work, don't bring them as a focus group. It doesn't serve anybody any good. You got to bring them at the beginning of the project, because that's when they will really work side by side with you as in partnership. So I also heard, how do we not come across as paternalistic, like with countries that are not as advanced as we are? Educating the public, it works in every country in the world. It's the same throughout. So that to me is one of the things that we should start thinking right away, is implementing patient education. And it doesn't require major resources, by the way, because I have done it in the sepsis world in the Washington area and the Baltimore area with $0. So it's possible to do it. Thank you so much. Appreciate it.
Thank you, Armando. Carla.
Thank you. I really appreciate all of the speakers, and take what Armando just said and flip it over to the human side and the veterinary side. As an extension veterinarian, I really appreciate hearing about the global efforts, and I would like to encourage everyone to think about how we can foster communication, collaboration, and integration of these messages, not only to the veterinary field, our veterinarians, our practicing veterinarians, but as well as our producers, our livestock producers on a global basis. I know many of our global partners, I've worked with USDA, FAO, we have extension and outreach and education programs, but I think it's really important that we don't forget to take what we've heard about the decision-making and the policy-making and get that message out to those who are actually on the ground using this information. So thank you.
Wonderful. And Jim.
Yes, thank you. Just a great sessions today. I really enjoyed all the presentations, really educational experience. The challenge I think we have is, like Paul mentioned, the agricultural side is really, plant agriculture is really in a minority in this group, and we need some additional support to get more input from probably the agricultural experiment station, where most of the agricultural work takes place, and obviously USDA ARS, the Agricultural Research Service, would be an important component to include in the discussions, along with the EPA, which regulates pesticide use in plant agriculture. I know that most of the people on this are medical doctors, and most of the people on this committee are part of veterinary science. So we're really to get at this black hole of, a lot of people just say the environment as a source. We really need to have a better understanding of what that means, and where these AMR sources are in the contributing to where they're developing and where they're coming from in entering into the patient or the animal patient or the human patient. So it's really, we need to go into that a little bit more detail, I think, in future discussions. Thank you.
Wonderful. Thank you, Jim. Well, I appreciate everybody's input. These comments will certainly help inform the working group's activities and how we start moving forward on this task of making progress on this report. I believe we got to all of our SGEs as well as our liaisons, and so RGEs, thank you for holding to the end, and certainly we can talk to you offline and continue those processes. But this time I want to transition it back to Dr. Musmar for a very important component of our PACCARB meetings for the public comment and innovation spotlight. So Dr. Musmar, it's back to you.
Thank you, Dr. Plummer, and appreciate everyone's comments. This truly will help direct us as we plan our working group sessions and the next public meeting that we plan on having in February. So please make sure that you stay up to date on the website for the next public meeting. That'll be a hybrid event in February, late February at that. The bad news is you don't get a break. The good news is we're going to continue with public comments, however, but general comments from everybody out there that isn't on the council. So this is a very important session of our activities. So we're going to start off with the public comments, and then we're going to continue on to the innovation spotlight that we have reserved separately. So now beginning with the public comment, just a few rules of engagement, please. Please limit your comments to 2 minutes. But before that, I just wanted to mention that we also had the option of written comment to be sent in to the CARB, C-A-R-B at HHS.gov. And we've already had letters that were sent to us by the American Society for Microbiology, the Food Animal Concerns Trust, 3 Pharmaceuticals, HealthWatch USA, and Vedant Ramji for their written comments. Thank you so much. They've all been provided to the council for their consideration. Now moving on to our public commenters. Once again, please limit your comments to 2 minutes. We are at capacity for the time that we have allotted. And we're going to start first with Jamie Jonker from the National Milk Producers Federation. Jamie, the floor is yours.
Great. Thank you. And good afternoon. I am Jamie Jonker. I'm the Chief Science Officer of the National Milk Producers Federation and a member of the Global Leaders Group on Antimicrobial Resistance. Today, I'm speaking in my role at the National Milk Producers Federation, which is a trade association that represents dairy farmers and the dairy cooperatives that they own in the regulatory and legislative arena in Washington, D.C. I'm going to talk very quickly about our commitment for what the U.S. dairy industry is doing to help address antimicrobial resistance. We are trying to address antimicrobial resistance through that One Health lens, looking at the animal, humans, and the environment. And we are doing this through our on-farm program, the National Dairy Farm Farmers Assuring Responsible Management Program. This program has about 99% of the 27,000 licensed dairy farms enrolled in the animal care program. In that animal care program, we have strong engagements with the veterinary community. In fact, we require that every farm that's in our program has a veterinary client-patient relationship that is documented annually through a signed form between the farm owner and the veterinarian of record. Some additional parts of our program in animal care include the requirements of a herd health plan, which includes animal health decisions to prevent, control, and treat common diseases. This, again, is required to be reviewed by the farm owner and the veterinarian of record on an annual basis. We have record-keeping requirements about antimicrobial use. Aligned with this, we have additional modules very specific to antimicrobial stewardship. To do this for the dairy farmer, we run it through the lens. We run it through the lens of a residue avoidance program so that we're using language that they understand, but it has, I think, important implications about the judicious and responsible use of antimicrobials on dairy farms. And then most recently, we have put out a biosecurity module that is thanks in part to the U.S. Department of Agriculture's NADPREP Cooperative Agreement Program. With this, we have been able to help strengthen the idea of everyday biosecurity and enhanced biosecurity, which again will continue to reap rewards on what our industry, dairy industry in the United States, is doing to help address antimicrobial resistance. Thank you.
Thank you so much, Jamie Jonker from the National Milk Producers Federation. Next, we have Kevin Kavanaugh from Health Watch USA. Kevin, welcome back.
Well, thank you very much. We wish to alert the PACCARB regarding the newly proposed CDC recommendations, which will almost assuredly promote the spread of bacterial and viral infections and worsen the epidemic of multi-drug-resistant organisms. The proposed enhanced barrier precautions for nursing homes are intended to contain MDROs, but they allow colonized patients with MRSA, CRE, and Candida auris to participate in normal facility activities. Staff are required to wear gowns and gloves with high-risk resident interactions, but even interactions with low risk of spread occur so frequently that spread can occur. Enhanced barrier precautions are also not supported by the predicate data which they were once based upon. It makes no sense to alert the nation regarding Candida auris outbreaks, but at the same time to allow colonized patients to roam around a facility. The CDC is also revising their 2007 guidelines for isolation precautions and not uniformly recommending healthcare workers use N95 masks when interacting with any and all patients infected with an airborne pathogen. This would include not requiring their use for seasonal influenza. In addition, negative pressure rooms are not routinely required for MERS, SARS-CoV-1, influenza, and SARS-CoV-2. We feel that this is a major step back in preparedness. We should be building negative pressure rooms and building our N95 supply chain and not discouraging their usage. Not using N95 masks for all airborne pathogens not only places workers and patients at risk, but also decreases supply chain demand, which may inhibit and shrink our manufacturing capabilities. These recommendations also pose a grave risk to the immunocompromised patient who must obtain health care and appear to be in conflict with the Americans with Disability Act. I would like to ask the committee to review these CDC recommendations and to help strengthen these proposals to protect both patients and healthcare workers. Thank you.
Thank you, Dr. Kavanaugh. Next, we have Zachary Wilder from Loyola University in Chicago.
Yeah, good afternoon, and thank you for the opportunity to speak before you all today. My name is Zach Wilder, and as a public health professional and graduate student at Loyola University Chicago, I've been inspired by the work PACCARB has done. It's clear that this council is committed to bolstering national and global efforts to eliminate antimicrobial resistance, and I commend you all for your specific focus on involving marginalized and vulnerable communities in all efforts. AMR represents nothing less than an existential threat to the health and well-being of people across the world. Already, millions die every year from resistant infections, with the projections indicating the worst is yet to come. But this future, one where tens of millions suffer from infections once easily treatable, is not set in stone. A recent report found that achieving full vaccine security of both existing and developing vaccines could avert upwards of 1.2 million deaths associated with AMR every year. While the World Health Organization, as well as this council, have frequently recognized the importance of developing new vaccines to combat AMR, more must be done to encourage their creation and distribution. It's known that several barriers hinder the full utilization of vaccines, including long development processes, profitability concerns, and complex regulatory pathways. These barriers are no doubt significant, but we have overcome them before. In fact, we just did. Just 3 years ago, in the face of the largest global pandemic in over a century, the United States government successfully developed highly safe and effective vaccines in the shortest time in history. These products were the results of years of investments in vaccine technologies, as well as coordinated and collaborative efforts with the private sector to eliminate regulatory, economic, and manufacturing concerns. The successes of COVID-19 vaccine development is nothing less than U.S. government at its finest. It's proof that no public health crisis is too great, no barrier insurmountable for us to overcome. We must do it again, but this time with vaccines to combat AMR. By learning from recent successes, by aligning interests behind a shared goal, and by taking bold actions that aim to protect the most vulnerable, we can ameliorate the threat of antimicrobial resistant bacteria. Thank you.
Thank you, Zachary. Next, we have James Graham from Reese Pharmaceuticals.
Hello, good to be with you. I'm James Graham, CEO of Recce Pharmaceuticals. Recce Pharmaceuticals is clinically the most advanced new class of antibiotic in the world at this time, the most advanced synthetic candidate. When I think to the challenge of antimicrobial resistance, as you may tell from my accent here in Australia, we're well positioned to broaden and globalize this AMR approach. From recently meeting with the Indonesian Minister of Health, Minister Budi, we recognise from a global perspective the significant unmet medical need of antimicrobial resistance. Whilst current antibiotics are derived from nature, the lengthy development phase and the cost of manufacturing is well known. We should cast our minds to the unique advantages of synthetic anti-infectives. These are yet to be harnessed. The fully synthetic anti-infectives that can intentionally be designed to have a broad spectrum capability, counter antimicrobial resistance, and have a cost-effective manufacturing process, something that has never been achieved with all existing naturally derived antibiotics to date. In our case, Recce serves as an example of how novel, wholly synthetic approach to the development of antimicrobials holds significant promise in the fight against AMR infections. Utilising multiple mechanisms of action, those we've created rather than found in nature, can rapidly target positive gram-positive bacteria, gram-negative bacteria, and their hypercellular mutations. We've shown to be safe, well-tolerated, and efficacious in phase 1, phase 2 studies of humans. It's available in IV and topical and is being studied in the vulnerable patients of diabetic foot infections, burn wound infections, and has clinical plans for UTI infections or urosepsis as a whole. The global health challenge posed by AMR requires a collaborative effort. I think we've heard that. The necessary infrastructure and resources to accelerate the development of innovative technologies that can treat AMR infections and achieve sustainable, meaningful global change. Thank you for the opportunity of this public comment.
Thank you, Mr. Graham. Lastly, we have Marilyn Bruno with Acor Inc.
Thank you so much.
Oh, Marilyn, we can barely hear you, Marilyn. Hello?
I was invited. Oh, yes.
Much better. Now we can hear
How's
you.
this
Go ahead.
better?
Yes, yes, yes.
Okay. Thank you. It's an honor. I was invited to address the UN General Assembly in 2016 on AMR. And at the time, I identified 3 gaps in the discussion. First was One Health, and fortunately, 7 years later, we are addressing that issue. Second was access, since in our jet age, the outbreak spread very quickly globally. The third was developing remedies for biofilm. None of the new drug candidates, and in fact, few people in the room were aware that biofilm was the first and often only resistance response of bacteria and fungi. It's the way they grow and colonize, and it's the way they protect themselves against environmental threats. This gap remains. As well documented for over a quarter of a century, every bacteria and fungi on the CDC and WHO lists of high priority pathogens are all biofilm formers. This is not a coincidence. They are hard to kill. Biofilm protects them. All of the biothreats, anthrax, tularemia, plague, are also biofilm formers. The bacteria and fungi form biofilm, an extracellular matrix to attach firmly to surfaces. Once they are attached, they are 100 times harder to remove and 1,000 times harder to kill. The surfaces they attach to are plant, animal, and human tissues, as well as inert, nano, and any surface, organic surfaces. You would need penicillin at 1,000 times the dose tolerated by humans to penetrate and remove a biofilm. ACOR is a small company that discovered in the ocean novel molecules that remove biofilm in minutes and prevent its formation for weeks. We've been validated by NASA, USDA, DOE, and many other agencies. And the point is, we can also potentiate obsolete antibiotics such as penicillin to kill the AMR pathogens at doses too low to trigger resistance, sub-MIC doses. This solves the problem of access and stewardship and closes the gap on One Health as well. And this is ACOR. We look forward to working with, we're the microbiology side of this story. We're looking forward to working with the policymakers and chemists who are going to help us bring our products to market, our therapeutic products to market.
Thank you, Marilyn. So I know that you're signed up also for Innovation Spotlight to continue this, correct?
Yes,
Okay.
indeed. And I'll continue then.
Just thank you. Just please stay on the line for us and hopefully your connection continues. So we appreciate everyone's public comment. Again, if you have anything that you'd like to provide the council with, please be sure to email CARB, as in bacteria, at HHS.gov. And next, we are continuing on to our Innovation Spotlight with our pre-registered commentators to highlight new and emerging technologies in the fight against antimicrobial resistance. We have this Innovation Spotlight that we started a few years ago, where similar to our traditional public comment section, pre-registered companies have this opportunity to share their work with all of us. We have five companies that are pre-registered to share about their technologies. This was open to everybody interested in a Federal Register notice and on the registration page, and the work must directly be related to combating antimicrobial resistance. Each presenter, you have 5 minutes flat, please. There is no Q&A following each speaker, and your slides will be part of the record and part of the presentations that are provided today in the YouTubes that'll be archived on the website. So we'll continue with Miss Marilyn Bruno. Do you have any slides for ACOR?
I do.
All right, keep rolling. You have 5 minutes now.
Okay, so we are looking at a biofilm of Pseudomonas aeruginosa. There are hundreds or billions of bacteria in that biofilm. Just so you know, it is a real thing. And next slide, please. This diagram shows how biofilm starts as glue to attach the bacteria to the surface and enable colonization. But notice how it grows, and it grows and grows. And inside that biofilm are multi-species of pathogens. They're sharing genes, and this is the danger of this horizontal gene transfer, which is triggering faster AMR. There are also persister or dormant cells inside that biofilm. They're impossible for any antibiotic or human immune response to kill. So the facts about biofilm, I alluded to some of them. 90% of hospital-acquired infections are associated with biofilm, as are 80% of all chronic wounds. And once the biofilm bursts, it spreads in air, water, and on contact. And the only remedy today is scraping. And we know this from plaque on our teeth. That is biofilm. The more we brush and swish, we're actually forming thicker biofilm. If the bacteria get into our bloodstream, the same bacteria in our teeth are going to enter our heart and cause plaque called endocarditis. Next slide, please. So our remedies were discovered in the ocean, where nature has figured everything out, and our product is a small molecule. Actually, we have 30 novel small molecules that remove biofilm 99.99% in minutes and prevent its formation for days. They kill the AMR pathogens and potentiate those ineffective antibiotics. This test was done by Lonza. Next slide, please. There are many tests on the ASTM standard tests showing AMR biofilm removal and prevention. The CDC at NIH send us the latest clinical strains of AMR pathogens, and we've been doing tests to see how effective our novel chemicals are, and these are some of the results. My favorite slide is the one on the right, which is potentiation. So you see that methicillin, gentamicin, penicillin, and vancomycin no longer work against MRSA and VRSA, but a tiny amount of them and a tiny amount of one of our chemicals knocks them down. They are gone. And the same results we are finding with other pathogens, other antibiotics, and disinfectants as well. Next slide, please. So join us. We have abundant data on how this works. When we showed the data to Dr. Anthony Fauci himself at the NIH, he said, I am giving you free preclinical trials for as many new drug candidates as you can deliver in half-kilo quantities. That is a gift. We want to start those preclinical trials and are looking for partners to help us make this happen. But it's in our reach. Most of our current work is in industrial biofilm, and we have a wonderful amount of data to share how our products are working, not only in vitro, but in the field and at scale. So thank you so much for this opportunity. It's a pleasure to address you all. This is a remedy that needs development, and we're happy to work with all of you. Thank you.
Thank you for joining us, Marilyn. Next, we have Keith Karen from SKM Instruments.
Thank you. I want to introduce a method to improve AMR detection. We have named the method FAST. That's an acronym for FAST AST. AST is abbreviation for antibiotic susceptibility testing. Just as introduction, my name is Keith Karen, and I've been a CEO of many companies developing instrumentation. My partner is Lauren Ziegler. Larry's a professor at Boston University. He's got 40 years of experience in spectroscopy and 20 years specifically in SIRS, which is what we are using for this method. And I'll explain that in a few slides. Next slide. It's not all showing up. Just as an overview, we have demonstrated in the lab accurate AST in 1 hour or less. But our goals are to provide commercially an accurate antibiotic susceptibility testing method to get profiles in less than 1 hour from clinical isolates. And I will also speak to situations where you do not have the isolates and you have to culture all of the antibiotics or all of the microbes. What rapid results will allow us to do is make more effective treatment without using broad spectrum therapeutics. And that, of course, will lead to better health outcomes, shorter hospital stays, and it should reduce the development of AMR pathogens by using the correct antibiotic or fungicide initially, rather than using the broad spectrum therapeutics. The principal innovation that we're using is an optical method. It's called SIRS. It stands for Surface Enhanced Raman Spectroscopy. And what we detect are the metabolic products produced by bacteria when they're in a low nutrient medium. And those are chemically, they're called purines. I give a reference to that from Dr. Ziegler. And the purines are in the bacterial, fungal, paracellular region. And what they do is they provide spectroscopically a quantitative MIC antimicrobial susceptibility profile. The principal general outcome for infectious disease is that when we combine this with partial blood sample growth, where we're assuming not very many bacteria are in the blood sample and we have to do some incubation, we can still provide AST profiles in less than 8 hours. Next slide. So just to show you how the method will work, fast MIC determinations, at the top, we are looking at E. coli 2452, and what we're showing is that it takes 24 hours for the gold standard method, which is incubating bacteria, growing them for enough that they give an optical density measurement that can be measured, and that typically is 24 hours. Sorry, this shouldn't be animated. Using the fast method, our method, we show within 1 hour, you can see our spectra, and these are called Raman spectra. It's a spectroscopy that gives very high information content. You can see going from the bottom, the peaks are decreasing rapidly. The important thing is that in both methods, the gold standard and our method, we both came up with an MIC for tetracycline of 2 milligrams per liter. Just to demonstrate what happens if the bacterium is resistant, we have the same bacterium, E. coli 2452. We look at the gold standard. After 24 hours, no matter how much antibiotic is present, you see a strong signal, some fluctuation. But with the fast method in 1 hour, again, we see the peaks are not decreasing, meaning the bacteria are not dying. And if you look at the same type of plot, then some fluctuation, but clearly ampicillin is not an antibiotic to use for E. coli 2452. And finally, there should be one more line. Yes. I don't want to bore everybody showing you 90 plots, but we have looked at 90 different strain and drug MIC experiments, and the agreement is within plus or minus 1 doubling concentration with the growth, meaning that the method matches the gold standard quite well. Next slide. Just to show you the workflow.
Mr. Karen, just to give you a timing warning, please, just 1 more minute. Thank you.
Okay. Just to show you how the blood sample would work, we're assuming, and we have proof of this, that 5.5 hours is enough to culture the bacteria. We're putting in 1 hour for MALDI to determine the species, and then 1 hour we do the fast, which is a 30-minute incubation, and then the SIRS measurement. Next slide. And then to summarize, the advantages, again, 1 hour from clinical isolates, 8 hours from a blood sample, accurate MICs. This technology is patented. The innovation, as I said, is SIRS. I want to stress it's phenotypic, so emerging pathogens can be detected. We don't need a library of existing pathogens to do our method. We can look at live, we have live dead distinction. We are not using DNA or genotypic type methods. And it's quantitative, and it could have AI to determine susceptibility, resistance, or intermediate. And lastly, it's simple, no calibration. It's applicable to all types of infections, blood, UTI, STD, TB, wounds, and it also works with fungi. So you can look at fungi and fungicides and their susceptibility. And thank you.
Thank you so much, Mr. Karen. Next, we have Thomas Heyman with the Sepsis Alliance. Welcome back, Thomas.
Thank you all. It's great to be back with you. My name is Tom Heyman. I'm the president and CEO of Sepsis Alliance. We are a national patient advocacy organization working collaboratively to prevent infections and improve the diagnosis and treatment of sepsis. We're also a co-founder of the Global Sepsis Alliance, which has affiliates in more than 90 countries. We also care enormously about AMR. We're seeing a great deal of exciting innovation in AMR, including disruptive antimicrobials, rapid diagnostics, home monitoring devices, and more. But we also need to make sure that all of our stakeholders understand what AMR is, what risks it has for us as individuals and for us as a society. For that reason, we believe that awareness and education need to be part of any conversation about AMR. Next slide, please. Sepsis is the body's overwhelming and life-threatening response to an infection that can lead to tissue damage, organ failure, and death. In other words, it's your body's overactive and toxic response to any type of infection. And sepsis is very common and very deadly. There are 49 million sepsis cases worldwide each year, with a very high mortality rate of more than 20%. And in the US, the numbers are not much better. We see 1.7 million cases each year, with 350,000 adults perishing. We see an additional 7,000 children die each year in the US, which is more than from cancer. And sepsis is now the #2 cause of maternal mortality in the US. We also see 14,000 patients each year in the US who require amputations to survive from sepsis that has shut down their organs and caused tissue to die. We also know that AMR accounts for about 10% of sepsis deaths worldwide. And that percentage and the numbers of sepsis deaths is only going to rise as more infections are harder to treat and will end up cascading to sepsis. Next slide, please. Given AMR's impact on society, it's alarming that just half of adults globally have even heard the word. And that's across, we did a survey in the US, but also Brazil, Spain, China, and India. And it's just about half the world has not even heard the word before. The good news is that when people are told what AMR is, they do respond with concern, and more than 2/3 see it as a major problem. So a real opportunity for education. We also recently conducted a survey of 150 US-based C-suite healthcare executives, and they shared some really interesting perspectives on AMR. Fully 90% see AMR as threatening to society. 88% believe the problem is getting worse. 85% say that the AMR may actually be increasing the potential for another pandemic. And interestingly, not shown here, is only 26% of hospitals give themselves an A for their own antimicrobial resistance, antimicrobial stewardship efforts. And 77% say that educating clinicians, caregivers, and patients is an important opportunity. And you can see that the need for education extends to knowledge of possible government shutdown solutions as well, as only 15% identified the PACCARB Act as legislation that could help fight AMR, only 15%. Next slide, please. There's a lot we can do, and Sepsis Alliance has been working hard with many of you and many partners to help get the word out. We created an education campaign, End Superbugs, that has been used to raise AMR awareness and drive interest in the PACCARB Act. The campaign has been seen by hundreds of thousands of individuals across the nation. We also conduct surveys like the ones I just shared with you with the public, ID physicians and pharmacists, C-suite executives, and others to help understand where the gaps and opportunities are for education and engagement around AMR. We also train healthcare professionals on infection prevention and antimicrobial stewardship, including via our spring AMR conference on April 10 and 11, which is expected to attract more than 3,000 participants. And we train advocates to understand AMR so they can more effectively push for policy solutions, including the PACCARB Act, via Sepsis Alliance's Grassroots Action Center, Sepsis Alliance Voices. Next slide, please. I want to thank you all for your time and attention and for your hard work on AMR, and I'm looking forward to working together. Together we can help defeat AMR. Thank you very much.
Thank you, Tom. Super helpful information. All right, next we have Adam Saltman, Hyperspectral.
Thank you very much. Hello, everyone. My name is Adam Saltman. I'm the Chief Medical Officer for Hyperspectral. Before I get started on my presentation, I'd like to thank the Council for allowing me to present what we're doing at Hyperspectral to address the very important health problem of antibiotic resistance. Next slide. Hyperspectral is a small Virginia startup company that is building a software as a medical device to detect antibiotic-resistant bacteria. And detecting ARBs as early as possible holds the key to rapid and accurate treatment. We do this by harnessing the power of spectroscopy, the ability to identify chemical and biological structures by studying the interaction of light with those structures. The magic of spectroscopy is its speed and simplicity. What I'm showing here is the overarching principle of how we are using spectroscopy and artificial intelligence to identify antibiotic-resistant bacteria. First, we shine light of a specific wavelength or wavelengths on a target, in this case, a bacterium. Some of that light will be absorbed, some will be reflected, some will be scattered away, and some will be transmitted through the target. Each specific wavelength, be it visible, ultraviolet, or infrared, is absorbed, reflected, or transmitted to a different degree depending upon its unique chemical properties. We then capture that reflected light or transmitted light with a camera and label the data accordingly. For example, if I were imaging Staphylococcus, then I would label the captured spectral data as Staphylococcus and build a data set of spectra by iterating this capture process. Once the data set is complete, with hundreds or even thousands of labeled spectra, we then use advanced machine learning techniques to train software to recognize the target. It is that machine learning model that becomes the final software as a medical device. Next slide, please. Now that I've covered the principles of operation, this slide shows the workflow we are developing and where we are now. First, we take a sample from a patient. It could be anything of interest, such as blood or sweat or urine or mucus. We then suspend the sample in a saline solution in a glass cuvette and put the cuvette in a commercial spectrophotometer. The spectrophotometer shines light on the sample and captures what is transmitted through the sample. The resulting spectral data are then sent to the cloud, where our artificial intelligence machine learning model, which is shown in the red rectangle, analyzes it and produces an output of a report where it says which bacteria have been identified in the sample. Because we are only taking swab samples from patients, the sampling process represents minimal risk to the patient. Because we are using a standard off-the-shelf spectrophotometer, gathering data is fast and does not tie us to any particular hardware. Because our software runs in the cloud, we can function wherever there is an internet connection. And I think this last point should be emphasized because unlike embedded software that is tied to a piece of hardware, cloud software significantly improves access to care and allows us to update the product frequently, thereby improving performance and adding new bacteria to our recognition library. In essence, we are taking the state-of-the-art in antibiotic-resistant bacteria detection from a microbiology lab test that could take days to a cloud-based test that can be done almost anywhere there is electricity and internet and in only a few minutes. Next slide. But we are only just getting started on this journey, and this is our task list that's ahead of us. As you can see from the table, we already have models that can detect staph and Pseudomonas. We will next develop detection models for the remaining escape bacteria, a group of bacteria that is known to have a very high prevalence of antibiotic resistance. And because not every escape bacterium is antibiotic resistant, we will also need to build models that can differentiate sensitive escape bacteria from resistant ones so that clinicians can make the correct decisions regarding treatment as fast and as accurately as possible. And all of this is going on while we are working on miniaturizing the spectrophotometer into something small, inexpensive, portable, and battery operated, like a digital thermometer or an ophthalmoscope, so that it can be literally used anywhere and by anyone with minimal training. Next slide, please. That was a very quick 5-minute or less overview of what we're doing at Hyperspectral. I hope I gave this topic some justice and whetted your appetite to learn more. Please feel free to reach out to me. My contact information is here. I'm always happy to chat and explore collaborations. And that's my contact information. Thanks again for allowing me to present.
Thank you, Dr. Saltman, for joining us. And lastly, we have Michael Weichert with Fay Pharmaceuticals. The floor is yours.
Thank you very much. My name is Michael Weichert, and I'm the CEO of FE Pharmaceuticals, FE being the atomic symbol for iron, which is at the center of our unique approach to addressing the antimicrobial resistance challenge. Next slide, please. Now, most bacterial and fungal pathogens have an absolute requirement for iron, which they obtain from their host. extracellular iron is only 0.1% of the iron in the human body, but that iron is the source for pathogens. Bacteria and fungi have specialized molecules called siderophores that are designed to obtain this iron and deliver it back to pathogen cells. We have our own iron sequestration response to serious infections called hypophoремia, which brings extracellular iron into our cells to limit its availability to pathogens. This tug of war over iron often tips in favor of pathogens in vulnerable patients, particularly those with higher levels of circulating iron. In addition to infection, our own inflammatory response to serious infections is also dependent on readily available iron, which macrophages need to amplify cytokine signaling. In serious infections, this process can spin out of control into what is often referred to as cytokine storm and sepsis. Next slide, please. FE Pharmaceuticals is developing an iron-binding polymer called DIBI. It has a very high affinity for iron, higher than the iron-binding affinity of biological molecules and siderophores. DIBI is designed to stay outside of our cells, thus binding only the extracellular iron that is the iron source for most pathogens. This iron is then rapidly removed from the body by urinary clearance of DIBI, which has a half-life of less than 30 minutes in circulation. DIBI is non-toxic, and since it stays outside of our cells, does not disrupt our own iron-dependent processes. DIBI stars pathogens for iron with serious consequences for pathogen viability, essentially augmenting our own hypothermic response. Next slide, please. DIBI has been studied in many different animal models of local and systemic infections. When administered alone, DIBI reduces the burden of bacterial pathogens by 100 to 1,000-fold or more, regardless of whether the pathogen is gram-positive or negative or drug-resistant. DIBI works in a wide variety of infection types and sites. In addition to its effectiveness against infections on its own, DIBI also works synergistically with antibiotic or antifungal agents, delivering better infection treatment than either agent alone. This synergy is agnostic to the antibiotic or antifungal agent or infectious organism. It is even effective in improving survival in animal models of serious sepsis. These results have been widely published in peer-reviewed scientific literature. Next slide, please. Our unique approach is developing a non-toxic antimicrobial agent that is not an antibiotic, yet has broad-spectrum antimicrobial activity. We do this by starving pathogens for iron without affecting host cells. Our polymer agent DIBI is synergistic with anti-infective agents, improving efficacy in combination. But the fear of development of antimicrobial resistance leads to stewardship of new antibiotics for last-line use. DIBI helps address AMR in two ways. There is no known path for pathogens to become resistant to DIBI itself, nor their need for iron. Nor is there evidence that this occurs. And DIBI also protects co-administered antibiotics from the development of resistance, which requires DNA replication and repair, which are iron-dependent processes. Thus, DIBI provides a first-line agent that can be used alone or in combination with antibiotics and antifungals to provide a solution that does not contribute to AMR. Thank you for the opportunity to introduce this to you. And if you'd like to ask questions or learn more, don't hesitate to reach out to me at the contact information on the left of the slide.
Thank you, Mr. Weichert with FE Pharmaceuticals. All right, well, that concludes all of our Innovation Spotlight presentations. Thank you all for joining us today and for sticking to time. I will now transition this to our chairs, Drs. Plummer and Jason. Please, Newland, close us out, please. It's been a long day.
Agreed. Well, I want to express my appreciation one more time for the speakers representing the U.S. government agencies. It was very enlightening. I want to thank the council, new members and more seasoned members for your time, your effort. I'm well aware that we've been keeping you here for 3.5 hours without a break. I'm also well aware that it's only days from a holiday season. And so I appreciate you helping us get this done before before the end of the year. And working group, we're going to be diving in as soon as we get back from a couple of weeks off here. So look forward to working with you on that. And finally, a huge shout out to the staff. Many of them are working remotely. They're some of them already on leave and taking time off of their leave, because this was when we as a council were able to meet. So huge shout out to the entire team there. Thank you for a great meeting. Jason, over to you, and then we'll close it out.
Yep. Always can call me Jason. Thanks to everybody. Awesome day. Have a wonderful holiday.
Happiest of holidays, folks. We'll see you in February. Bye. Happy New Year.
Produced by the U.S. Department of Health and Human Services.